Hi, I'm Dr. Julio Gutierrez. I'm a transplant hepatologist or liver doctor at Scripps Center for Organ Transplant. Today, I'm going to talk about the most difficult challenge we have in managing our patients, which is ascites. I'm going to walk you through how to take care of your ascites and help you understand where it comes from and what are the possible solutions to deal with it in the future. These are my disclosures. I have no real conflict with this presentation. So what is ascites? Ascites is fluid in your belly. The first sign you have it may be your belly is distended and your ankles are swollen. If we take a little bit of the fluid out, it looks like urine, and it's usually yellow or straw colored. But it's not urine. It's actually rich in protein and immune defenses, and it has all the components of blood except for red blood cells. Draining ascites is possible, but it can make malnutrition worse. However, sometimes it's necessary. So here's what I'm going to talk to you about today. First, I want you to understand ascites. Why do you have it and what does it all mean? Then I'm going to talk about the ascites removal procedure, which is called paracentesis. Ascites can be removed by using a small needle and tested for infection or other qualities. How do you manage ascites? Well, step one is getting control of your diet. And that is going to require you to be on a low sodium diet and monitor how much water you're drinking every day. Medications can help. And I'm going to talk to you about how to use the medications I call Bert and Ernie, or Lasix and aldactone. Sometimes I replace aldactone with amiloride for my male patients. What else is there to do if we can't get a hold of your ascites with medications? Well, we also have a special shunt. It's called a TIPS, and it can help control ascites when severe and not responding to medications. Finally, transplant, or the gift of life. Transplant of the liver can be the cure for ascites. And when we see ascites being uncontrolled, it's often a sign that liver transplant or death is near. So on the left, I want to show you the healthy person where there's no ascites. And then there on the right, you can see ascites where fluid is collecting in the abdominal cavity. And that's usually from a sick liver. You can see the liver there that has cirrhosis asking for help. So ascites can come from heart, kidney, infections, or even cancer, but the most common cause is cirrhosis of the liver. As soon as I say cirrhosis, my patients get confused. What is cirrhosis? Cirrhosis does not specifically refer to liver disease from alcohol. It can come from many different causes, including hepatitis, fatty liver, alcohol, or even rare immune diseases. And there on the left, you can see what a normal liver looks like. Nice and smooth, beautiful colors. If we take a biopsy and we look at the cells under the microscope, they have a uniform appearance, lots of little pretty pink cells. In stage 4 scarring of the liver, which is cirrhosis, when we look at it under the microscope, we see thick bands of scar tissue. And if we take out that whole liver and we examine it, we'll see it's much smaller than the normal liver. It's got lots of bumps on it. It's damaged and burnt out. Yes, the liver can heal, but usually not past severe scarring of the liver. When somebody hits stage 4, it's very unlikely that they'll heal their liver, especially if they have ascites, although it can happen. And I have miracle stories of my patients who do their best to control their liver disease, especially if they can cure their hepatitis, lose weight, or control their alcohol consumption. The liver can improve, but it's not what we should always expect. So now you understand that when the liver has excessive scarring or cirrhosis, it's damaged, it doesn't let blood pass through easily. You can think of a normal healthy liver like a sponge that allows fluid to pass through it and get to the other side so it can get to the heart. Well, when the liver has cirrhosis, it's like a block of concrete and fluid cannot get by. And that causes blood to get shunted away from the liver. That high pressure also causes that liver to sweat fluid into the belly, and this is ascites. That fluid can also creep up through little tiny holes that separate in the diaphragm, which separates the lung and the abdomen, and cause fluid to collect, usually on the right side. That one's called a pleural effusion or hepatic hydrothorax. So what does this all mean? Well, if you have cirrhosis from stage 4 scar tissue, and now you're starting to develop ascites, we can recategorize you. So instead of the 4-staging scarring system, we can now categorize you by your level of cirrhosis. And we have another one that's A, B, and C. A is the best, C is the worst. With severe ascites, the score is at least B. And when patients get to that level, survival tremendously decreases. And over the next 5 years in a patient who develops ascites, we can expect a 50% chance of death. So patients who have ascites should be referred to a liver transplant program because a liver transplant can rescue you and keep you alive. We just have to manage this ascites in the meantime. So here's this picture of the damaged liver. You can see that liver, it's bumpy. He has cirrhosis. And when blood comes up that blue vein, which is called the portal vein, it cannot get through. So it gets retransmitted towards the spleen, which causes the spleen to get big and swollen because it's consuming platelets. This causes veins to develop in your esophagus, which can spontaneously bleed, called varices, and also is the reason that ascites develops in the belly because of that high pressure. What are the consequences of that? Well, the belly starts to get swollen. And that's how you know you have ascites. You feel very distended. The first sign may be that your belly button starts to stick out. That's called an umbilical hernia. Sometimes these are harmless, but they can be dangerous if the bowel gets trapped. That usually causes a lot of pain, tenderness, and a red appearing hernia at the umbilicus or the belly button. Also, many patients who have ascites will develop swelling or edema of their lower extremities or legs. Also, unfortunately, people may also develop other hernias such as inguinal canal hernias or groin hernias. All these are signs that you've developed ascites. Well, we can take it out. And sometimes it's required to test the ascites if we suspect an infection. And if that's happening to you, what will usually occur is that we take a small needle and remove just a little bit of fluid to test it for infection. That's called a diagnostic paracentesis. On the other hand, if ascites is uncontrolled, we may perform a therapeutic paracentesis, and that's where we take out bottles of fluid. Usually each bottle is a liter, and it's usually safe to remove about 5 liters in most patients. To do that, a catheter is inserted into the abdomen, and the catheter communicates with the ascites and drains it usually by gravity or a pressurized tube to a bottle. And my preference is that we always stop at 5 liters. So sometimes it's necessary to do this removal of ascites through paracentesis, either when there's an infection suspected or when it seems like medicines aren't working. But if we take out ascites too often, we can make malnutrition severe. Also, taking all that fluid out can cause very low blood pressure, and you can even die. So when we take a lot of ascites out, which usually around 5 liters, I also always want my patients to get an IV with this yellow fluid called albumin. And that balances out the pressure in your blood and ascites to keep you from getting ill from the big volume removal. I'm going to mention this several times, 5 liters. If they're doing 10 liters, 12 liters, I saw on the internet, there's one guy getting a 19-liter tap that can kill you, okay? If there's too much fluid in there, what we do is we schedule a weekly paracentesis, get the fluid down over 4 to 6 weeks and get control of it. We don't want to take it all out at once. That can be harmful. And that's why I've developed my own rule book that I want to share with you, okay? It's important for you to understand all this stuff. I'm going to take my time. That's why I made the video. I want you guys to hear it. You can watch the video over and over again, share it with your children, your loved ones, so they understand what you're going through. Paracentesis is a sterile procedure, okay? When doctors do this procedure, they should be gowned. They should be cleaning the site, using all sterile equipment. They're going to open up a special kit, okay? It's a sterile procedure. They'll use an ultrasound to look for a safe spot. If they're not using an ultrasound, something's wrong. All right, we'll never take out more than 5 liters unless I have approved it. And if I approve it, the max I would probably ever do is 7 liters. Usually I just like to keep it to 5, okay? It should be yellow and clear, see-through. If it's cloudy or white, that could be a sign that you have fat or an infection in your fluid. If it's very bloody, that's not normal either. Sometimes a little bit of blood might be normal, but if it turns dark red, that's probably a sign that you're having a simultaneous bleed into your ascites. I always want you to get albumin if they're taking out more than a bottle. All right, that's usually the large volume paracentesis. I want to see you get albumin every time. It can really help. In fact, it can also help you from needing more paracentesis in the future. Usually, I don't want you to get more than 1 paracentesis a week unless you're hospitalized. And I just want to minimize these paracentesis. I want to manage you medically instead. And the reason for this is because if we start taking out a lot of ascites, you will see that your arms and legs start getting very skinny. We knew this from ancient times. There's an ancient Mayan there on the right with ascites and distended umbilical hernia, skinny arms and legs. The same thing still happens today. When people develop ascites, it causes malnutrition itself because you can't eat. It's like being pregnant. You will have no appetite. And plus, when you have liver disease, you don't absorb nutrition correctly. And many patients are also taking lactulose and other medications which exacerbate malnutrition. So draining that fluid is a big loss to you. You're going to lose proteins. You're going to lose immune defenses. You're going to lose nutrition that your body works hard to make. Sometimes we can't avoid it, but I want you to understand the pitfalls of frequent paracentesis. What about the goals of medical therapy? Can this be managed with medicines? Yeah, it can. What's the goal, right? First, the G, get control. Get control by treating the underlying liver disease. Many liver diseases are curable. For instance, I can cure hepatitis C in 8 to 12 weeks. All right. If you stop drinking alcohol and that's the cause of your liver disease, that's a cure. So that's the goal, right? To get control. What about O? Oral intake of water and salt need to be carefully monitored and limited. Unfortunately, water isn't always the solution. I know many people have the idea it's healthy to drink a lot of water. It is when you're normal and healthy. But when you have cirrhosis and ascites, oftentimes it just makes things worse. So we have to monitor how much fluid we're urinating and how much we're taking in. Salt is enemy number 1. What about the medicines? Well, there's a couple medicines I really like to use for my patients with ascites, and I'm going to talk to you more about them right now. Aldactone is for the females, amiloride is for the males. I'm going to explain why I like to switch the medications for males and females. Those are diuretics that conserve potassium. And then I have another diuretic called Lasix that causes potassium loss. But when I use these medicines together, I can achieve the perfect balance of potassium in your blood, which is super important for normal heart function. So the big question my patients have is, how much water should I be drinking? Well, Dr. Gutierrez always likes to talk about this because I've learned over my career that this is a place where I can really make mistakes with my patients by not explaining how much water to drink. right? So I want you to have very strict fluid restrictions, right? You gotta monitor your water intake. Be sensible about how much fluid you're taking in and try not to drink too much water. The right amount can vary from person to person, but it should be about 5 to 6 8-ounce glasses a day, or about 1.5 to 2 liters per day, right? That's 2 bottles about this big, right? Maximum. Preferably 1 bottle this big and drink the other bottle about that big. And what would be helpful is if you keep track of all your fluids so you know how much you're taking in. If you're doing protein shakes, that doesn't count against your total water intake, okay? It would be also very helpful if you monitor how much you're urinating. You'll know exactly whether you're hitting it right. So remember, never more than 6 glasses of water per day. These are 8-ounce glasses, right? If that's getting confusing to you, buy a water bottle this big that's a 1 liter, fill it up every day, and you'll know whether you're drinking about 1.5 liters per day. This is so important. If you're drinking 4 liters of water per day, you'll never get control of your ascites. Dietary sodium restriction. This is another really big challenge for my patients, right? But the problem with liver disease and ascites is the body can no longer concentrate sodium appropriately. And the urine becomes dilute and the body hangs on to the sodium, which causes the swelling. And the other odd thing is that the actual sodium levels in the blood may be low, but the total body volume of sodium is high. So I really need you to try to eat at home as much as possible so you have an idea of how much sodium you're taking in. And do your best to avoid anything out of a can or a box so you can make sure you track the sodium intake. And so here on the right, you can see about how much sodium is in different things. And a slice of bread surprisingly has 230 milligrams of sodium. So if I tell you that you can only have 2,000 milligrams a day or 2 grams a day, that means you can only have about 10 slices of bread with 230 milligrams in it. It's not much food, right? Or 3 ounces of sodium or 3 ounces of turkey can have up to 1,000 milligrams of sodium. That's not a lot of food, 3 ounces. So you could have 6 ounces of turkey all day long. That could be your only nutrition if you're eating too much sodium. So, I mean, look at these numbers. I mean, for me, this was an eye opener to spend some time learning about how much sodium is in our food. Here's a sandwich. Remember, you get 2,000 milligrams of sodium a day. This is one sandwich, 1,500 milligrams, right? Look at the mustard, the cheese, the turkey. I mean, this is a lot of sodium just for a little sandwich. And you can try to make it a lower sodium sandwich by making low sodium choices, but still, one sandwich is 1 gram of sodium, 1,000 milligrams practically, the low sodium sandwich. So we really got to make some smart food choices here because you need the nutrition. I've told you, you're malnourished. You need the protein. So even low sodium foods that have that on the label can be risky for you to take, right? Fruits, vegetables, grains, unsalted meat, fish, poultry, beans. Those are going to be very low sodium choices. Usually these things will not come in a can, right? And you can get a lot of nutrition with low sodium by eating at home, doing your research about food, making sure your food's not cured or salted. You're looking at labels, you're checking where's that sodium line, 1%, perfect, all right? That's a perfect amount of sodium here. You could eat 1,000 of those cans, right? You could go crazy, 100 cans. And which protein should you be eating? Well, look at this. Here's steak and salmon. In an 8-ounce piece of steak, 166 milligrams of sodium. That's nothing, right? Same thing with the salmon, 99 milligrams and 8 ounces of salmon. That's nothing. You could eat so much steak to get to your 2,000 milligrams a day, right? What about other foods? Well, obviously 1 tablespoon of salt, which is not much, right? That's just going to fill up your hand. That's 2,300 milligrams of sodium. 1 bouillon cube, if you're making soup at home and you're putting bouillon cubes in your soup, it's a lot of sodium. You can't do it. Soy sauce. One of my favorite patients loves soy sauce. Look at that. Just a little bit of soy sauce, 1 tablespoon, 1,000 milligrams. Beef jerky. Look at that. Ham, salami, bacon. I mean, these are ridiculously rich in sodium. 1 slice of salami, right? So look at that. You could have a 3/4 pound piece of fresh steak and have the same amount of sodium in 1 slice of salami. So the amount of sodium in the steak is about 20 milligrams, whereas in the salami you have 220 milligrams per ounce of sodium. And that means you can get 10 times the protein by eating unsalted steak compared to salami. It makes such a big difference if you can keep an eye on that sodium intake. And I'll tell you, it's the main reason I struggle with my patients when they don't understand the sodium. It's a big challenge. Everybody needs help. Managing salt is usually at least half the problem here. It's not your fault. Ascites is hard to control. It's hard to understand where the sodium is. If you can't eat at home, if you can't cook for yourself because you're sick, it makes it even harder. We have transplant nutritionists at Scripps, Center for Organ Transplant, who can help you with this. But if we fail with diet, there are more options. So I don't want you to lose hope. And these are my 2 favorite characters, Bert and Ernie. I like to use this analogy for Bert and Ernie because when I talk about Lasix and aldactone, I want you to learn how to use these medicines together so you can control Bert and Ernie, right? So because every time you're going to take a Lasix, you're going to take an aldactone or a Miluride. Lasix, it lasts 6 hours. When you take the Lasix pills, it will cause you to pee for 6 hours. That's why they call it Lasix, not Lay7 or Lay8, all right? Lasix. It's also called furosemide. You might see that on your pill label. And if you're dosed about twice a day, I recommend you take 1 pill at around 8 in the morning and the other one about 2 in the afternoon. And that will avoid you urinating all night. There's some big side effects from this medication related to muscle cramps. So you got to keep an eye out for the muscle cramp or lightheadedness. If that's happening, let us know. That's the Bert. The Ernie is aldactone or Miluride. And these can be usually taken in the morning and you don't need to split the dose. There's a special side effect for aldactone that occurs usually in the men, which is swelling or painfulness of the breast. A Miluride is the alternative. And usually I like to start my male patients out on a Miluride. So I want you to learn this. If you're gonna reduce Bert, then you'll reduce Ernie, okay? And we can teach you how to do that over time. But that's really the key. Or if you're not doing well, you can increase them. And that's going to be key for you to understanding your medications. So this is usually what I want my female patients to be on, the spironolactone and the furosemide. These are diuretics that can be paired together again to control the potassium. That's what the spironolactone looks like. It's also referred to as aldactone. The furosemide pills there too. It's got the fancy little numbers on it. And the key here is that if you're on about 50 milligrams of aldactone, you should be in about 20 milligrams of Lasix. If those aren't working, what we do is we increase the dose down to 140. And if that's not working, again, another paired increase of the medication. The key is they're always going to be paired. If you're doing really well, you can back down. If you were at 280, you can go back to 140. And do that. And that's why I want you to learn how to use these medicines together so you can see, oh, I gained 4 pounds. My legs are swollen. I'm going to increase Bert and Ernie now to 200 milligrams of aldactone and 80 milligrams total of Lasix. It's easy as that. Oh, my legs are better. I'm not swollen anymore. I'm going back to my usual dose, which is 100 milligrams of aldactone and 40 milligrams of Lasix. This is a really powerful tool for you as a patient. You can control your diuretics. Yeah, you got to let us know. Hey doc, this is a good portal message. Hey doc, I'm increasing my diuretics. Okay, let's get some labs this week and we'll check in after a few days, see if you're feeling better. Hey doc, I increased my diuretics. I'm feeling fine again. Okay. Go back to your usual dose. Usually it takes 3 or 4 days of a higher dose to get control of diuretics. If it's not working at that point, we need to review the system. Okay, so this is for the guys. This is a slight change for the guys. I found over time that my patients who are males do not like to take spironolactone. It's actually a more effective medication than amiloride, but it causes enlargement of the breast in men. So amiloride is preferred. But the same concept here, okay? Same concept. When you take the amiloride, you're going to take the Lasix. They have a pair. The amiloride can be just taken once a day. At high doses, the Lasix is usually taken twice a day. If you're getting swollen, you can double up your dose, do it for 3 or 4 days, go back down on both. The key here is always Bert and Ernie are paired together. So look, we got a Bert and Ernie playbook here too. You're going to start at the recommended dose that we're giving you, and you're going to follow plan for labs. I might say you got to do labs every 2 weeks or every 4 weeks or weekly, depending on how serious I think the situation is. And then I want you to go home and weigh yourself and monitor how much you're drinking, how much you're peeing. And then when you get into an ideal weight and you can hang out at that, and especially if you feel like, well, maybe I'm taking a little bit too much, we can try to reduce the diuretics. Or if you're not getting your weight down or it's getting worse, let me know. Call me. Send me a portal. If the weight is down and you're maintaining it and you're doing good, you can try to reduce the diuretics. I'm okay with that. And if successful, if say you reduce it 50% and you're feeling better, let's just stay there for a little while, see how you do, okay? But if you go down and the edema and the ascites comes right back, go back to your original dose, okay? And let me know that that didn't work. What about side effects? Well, we know all medicines have side effects. Even the best of medicines will have a side effect. So, since these are diuretics, you're going to be peeing a lot. It's possible you could get overly diuresed and feel dizzy or even dehydrated. If that's happening, stop taking Lasix and aldactone or amiloride and let us know. Okay, if you're feeling very dizzy, just stop. It's also common to have cramps. Let us know. We should check some labs, make sure your electrolytes aren't off. Sometimes you need a little bit of extra potassium in the mix here or some magnesium. So let's just check some labs if you're not doing well. And there's also some treatments. I find the weekly albumin infusions can really help my patients with cramps and uncontrolled ascites. So that might be a trigger for me to start setting you up for weekly infusions of albumin. Again, I will correct electrolytes if I find they're off. Sometimes I want you to try a special medication like quinidine or even muscle relaxants, all right? The key here is don't suffer. Let me know. Let's review the situation. What if you're taking the medicines and it's just not working? Well, it happens. Even if you're doing your best with the low sodium diet and diuretics. Again, this may be a trigger for me to try to get you on the albumin infusions, and we can schedule this weekly. Sometimes I also might want to start a medicine called midodrine, and that can really improve the situation from time to time. Or we need to start scheduling regular paracentesis. And that's a bummer because, again, that can really exacerbate your nutrition status. So instead of doing that, I might talk to you about a special procedure called TIPS and start to prepare you for liver transplant. And I know that sounds like a big deal, but I'm going to talk to you more about liver transplant and TIPS. And it's an important discussion for you to have if your ascites isn't well controlled. And remember, the key problem here is the high pressure in the vein leading to the liver because of the liver being very stiff and like a concrete block. So one solution for this could be to put a small tube across the liver so that blood can bypass the liver and get back up to the top part of the body or the heart. We call that tube a TIPS, T-I-P-S. And the TIPS can be a real relief for patients who have uncontrolled ascites. It's kind of a big deal though. It's a tube that we're going to put across your liver. And although we don't expect something bad to happen, it's possible that things can happen from time to time. All right, so when we start to prepare for TIPS, I want you to understand that liver transplant is imminent. And I call the tips a bridge to liver transplant. What are the risks and benefits of tips? Well, rarely the tips can cause liver failure, which is why I'm going to prepare you for liver transplant if we plan on a tips. Confusion from liver disease or hepatic encephalopathy can occur with tips about 50% of the time. Usually it's medically controllable with Lasix or with lactulose and rifaximin. But occasionally we have to adjust the tips, reduce the size. We can't take it out. It can never be removed until liver transplant, but we can adjust it and make it a little smaller or a little bit bigger. But remember, it's not a liver transplant. It's a bridge to liver transplant and not a cure for cirrhosis. I do have some long-term survivors of tips, some people who are 10 years out from tips who never got a liver transplant. But I still believe that many of those patients need liver transplant. And in fact, if liver transplants were more plentiful, then we would probably do transplants in those patients because they would do better and they would have a higher quality of life. But unfortunately, it's hard to get a liver transplant. But the big benefit of the tips is most patients have good control of their ascites after tips. My patients usually do very well after tips. I'm very careful with the tips, but sometimes it's needed. And it can be a real benefit to my patients who are having severe malnutrition. Remember, the cure for ascites can be liver transplant. And that is one of the greatest things I can do for my patients who need it to help them get the gift of life. And post-transplant, ascites is cured. So if I'm talking about transplant, you're going to learn more about the process. We can look at that video together to learn more about liver transplant and what my team will do with you through that process. It's a special thing. So remember, you can control your ascites. There is a way to manage ascites. First, you have to understand it. Where is it coming from? Why do you have it? We'll talk about the paracentesis, diet, medications, the TIPS procedure, and transplant. All these are very important for you to understand. If you missed it, that's why I made a video. I want you to watch this video over and over again. Share it with your family. You might have some questions about this. We can talk. We can talk about it. You know, here's my office number. Julio Gutierrez, that's me. Office number is 858-554-4310. I have offices throughout San Diego County. Torrey Pines is where my hospital is, Scripps Green Hospital. If you're not feeling well and you're going to go to urgent care, go to my urgent care, Scripps Green, ask for me. Say, Dr. Gutierrez sent me here, okay? I go to other hospitals throughout the Scripps system, so if you're someplace else, ask for me. I can come see you in another hospital. But